Thank you, Rachel. Good evening, everybody. Thank you for joining us this evening. I can see a few people are just waiting for their audio to connect, so I'll just give it 30 seconds before we kick off, and we can fire away. There we go. That looks like everyone's in. Fantastic. Well, look, as I say, thank you very much for joining us this evening. It's I think this is Rachel be able to home. I think we're on our 8th Densura and Friends, which is fantastic. So today we are joined by Robert Dyas from ProDental. Robert and I have got to know each other a number of years ago, and as part of the growth of the Densura Indemnity, when we met with them, their ProDental side and the CPD was really important to us, and something that we wanted to offer to all of our members. So for anyone on the webinar this evening who is a Densura client, as you'll know from either whether you joined in the last 18 months or renewed in the last 18 months, the ProDental membership would have been included. So if for any reason you're unaware of that and that's news to you today, do get in touch with us next week or later this week, sorry, and we can talk you through. So we have got, as I said, we've got Robert for well, up to an hour this evening. So really looking forward to this webinar. So I'm not going to ruin it, but it sounds really interesting. And what I would say is, while we're going through it, there's on Zoom a chat function. So if you do have any questions, if you could just type them in, and then at appropriate time I'll grab Robert's attention and we can go through those questions. And then obviously if there's anything that we haven't got through till the end of the call, we'll do a quick run through of any additional questions when we get to the end. But if you could just use that function, and I'll do my very best to get those questions answered at the appropriate time. So yeah, well, without any more time, I will get cracking and hand you over to Robert. So Robert, thank you again, and over to you.
Okay, thanks so much. Thank you everybody for joining me this evening. We're going to go a quick run through of oral surgery and some top tips, which I hope will be helpful to you. We're going to try and make this as interactive as we can in this sort of environment. So there's a free app or a link to click onto. Use your QR code with your phone or go on by another device and enter this code, and it'll allow you, when certain bits come up, to answer questions or ask questions. Okay, so a little bit about me. I'm an oral surgeon, qualified a long time ago, don't go there. I've had a number of different kind of aspects to my career, both in academic oral surgery, teaching undergraduates and postgraduates, also ITI fellow, ADI director for a number of years, and always had a keen interest in education, both undergraduate and postgraduate. And that's kind of how we set up ProDental, and I'm going to go a very brief chat about that. I used to work for CopDent, which we used to organise the courses regionally and nationally for dental dentists at the time, because it was just dentists who had to do CPD. And we used to work quite closely with the GDC, which was always a challenge even back then. And they kind of announced virtually overnight that they wanted to make certain bits of CPD mandatory. And they said, okay, we want you, by the end of this year, we want you all in the UK to have trained up all dentists in these topics. And we just said, there aren't enough lecturers. There's nearly 40,000 dentists at the time. We can't do it. My wife's background is in designing open learning and running learning platforms. So that's how we set up ProDental. Initially, we worked for NHS England for a number of years, and we have always remained totally independent. So it was never actually planned as a business as such. It was just an opportunity that nobody else was really addressing. So we created a platform to do it. When we first started, the internet was so poor, it was kind of 15 years ago. We did things slightly different way. But the first thing I'm going to do is ask you whereabouts you're all based. So if you can go onto your Menti. Go on, more than that. You're not all based in Somerset. I'm going to get you using Menti. York. I lived outside York for a little while. Wrexham. Oh, okay. More. Go on, go on, go on, go on. Okay.
We've got a whole load on the chat as well.
Oh, okay. Read out the chat then.
So we've got East Anglia, Dorset, Derby, and Peterborough.
Okay, so get to use the Menti next time because it'll be more useful for you. Okay, let's just close that voting and move on to the next slide. Okay, so I say ProDental, we've been going for a lot of years and just kind of quietly getting on with it. Started 15 years ago. We've always been completely independent. So as Tom knows, we've always avoided particularly dental companies who produce products, dental supplies who are wanting us to kind of promote their products. So we really aren't interested in that sort of thing. It has to be independent for us. All content is quality assured. We have a very large and very well respected editorial board. We've won, I think for the last 5 years now, the best e-learning for in healthcare company, which is a kind of proper award. We've currently got well over 33,000 subscribers, and I think we're in 72 countries around the world. So it's not just UK. We have over 450 courses on there at the moment. We do an average 2 live web week. You've stolen one of my webinar slots this week, so we've only got one this week. So we've got Bhavna Doshi doing one on Thursday evening this week, but I think we've got 3 or 4 next week to make up for it. We've got well over 900 hours of ECPD. You will not be, if there's a topic you want, it will be there, I can pretty much guarantee it. And it's for the whole team. We do specific courses just for dental nurses, technicians, hygienists, therapists, practice managers, and dentists, and also specialist dentists as well. Okay, so these are some of the organizations that we work with. We do obviously a lot with Tom and Densura, which I think works incredibly well. We do a lot with the College of General Dentistry, Ministry of Defence, a lot of bigger dental corporates, and also dental organisations and dental charities. We work with World Health Organisation a number of times as well as Pritchard and Dentaid. Okay. These are just some of the speakers who spoke in the last year for us. And this is the collage we put up for International Women's Day. So it's kind of a who's who of dentistry and medicine within this list. And a number of these people have spoken for us a number of times. And yeah, it works very well. These are just some of the recent courses we've had. We tend to run our webinars in slightly different ways. So we'll often have panel discussions. We'll actually make them quite emotional. So the mouth cancer one we've got at the top here, we discussed, we had 2 patients on there actually discussing their journey, their real life journey, what it was like for them and what they'd like to have been told by their dental teams and what perhaps they wouldn't like to have been told. We also had partners as well as maxillofacial surgeons, dentists, hygienists, therapists. Vaccinations, that was an interesting one when we all thought that vaccinations were going to be mandatory in England. And then at the very last minute, they pulled it. But we deliberately picked Jason Leach, who's actually a dentist, but he works for the Scottish Government, and Stephen Riker, who's a psychologist who works for SAGE. That was a fascinating meeting. It is well worth watching that. Safeguarding, we had the head of safeguarding for NHS England, the national head, Kenny Gibson, chaired that meeting. And sustainability in dentistry, we've done a lot of work on sustainability. There's a webinar on it, which looks at all aspects of sustainability. We've also got an e-learning course, which we've just launched on that. Okay, and this is just some of the stuff over the last year or so. So pretty much every area you can think of, we'll have something on there. Okay. Right, so to get on to top tips in minor oral surgery. So this is something for you to use your Mentimeter for. So what aspects of oral surgery practice are most challenging for you and why? Which bits would you like me to talk about? Which bits do you find most difficult? Just put anything in there at all, otherwise I'll talk about random things. Retained roots, okay. Anything else? Retained roots, medical issues, difficult extractions.
We've got a comment actually in the chat as well. So tips for extractions of root canal teeth. Interpret an X-ray to see if the roots are in the sinus or not.
Yeah.
If they are really in the sinus or just overposed.
Yeah.
So yeah, that was just the things that came through on the chat.
Brilliant. Okay, so retained roots, flaps, root extraction, suturing. Okay, coverage of sockets. Okay, that's fine. Right. Okay, let me just take a screenshot of this so I remember it. That's good. Okay, I'll close the voting on that. Okay. So I will go through those, and I'm just going to go through kind of elements of patient preparation. One of the things that I always say to patients, and it kind of comes from almost from a medico-legal aspect, is you don't always, even though I'm an oral surgeon and I take an awful lot of teeth out, I do lots of other oral surgical procedures as well, you don't always know how complex a procedure is going to be. So you've got an idea, but you often don't really know until you've probably started the procedure. I will always err on the side of caution, really to reassure the patient, in as much as I'll tell her if it's an extraction or some retained roots, I will say it will take me either 10 minutes or whatever my kind of long time would be, 40 minutes. It'll take me between that. And that reassures the patient straight away that if it is taking more than 10 minutes that they expected, that something hasn't gone wrong. Always overestimate how long you think it's going to take, because that is very incredibly reassuring. On the side of caution as well with local anesthesia, always make sure that the tooth is fully anesthetized. Are you all fairly confident to guarantee anesthesia on a tooth? 100% guarantee it? You can put it, there isn't a mentee on this. %. Okay. Pretty much. Okay. What? Oh, I'm sorry. No, no questions. 90%. That's pretty good. That's pretty good. Just one thing to kind of get. The thing with surgery is you've got to guarantee anesthesia, because if you can't guarantee anesthesia, you're going to really struggle to do the procedure. And I know something that I suspect none of you will have been taught it, depending on where you've been taught. But with a very hyperemic site, can you always guarantee anesthesia on that tooth? So if you've got a patient comes in, the tooth's incredibly painful, throbbing, been awake all night, can you guarantee anesthesia, do you think? 100%, Claudia, I'm impressed. Can't. It is more difficult because it's all very well with the non-hyperemic teeth, but unfortunately the teeth that come out aren't always that way. They're often hyperemic, painful, because that's why you're taking the things out. What I would always do is look at the medical model, and if you're wanting the references afterwards, I can give you those. But some incredibly good references out there to show that if you give the patient, so a patient comes in with a hyperemic tooth, it's really, really painful. It doesn't matter how good your anesthetic technique is, you cannot guarantee 100% you're going to get good pulpal anesthesia to be able to take a tooth out. So what I would always do is give them, if possible, a non-steroidal about 10-20 minutes before the extraction. which basically for me means when they come into surgery, because by the time I've numbed them up and got everything ready, it's going to be around about 10 minutes or so. You giving a non-steroidal such as ibuprofen, 400 milligrams for a fit and healthy adult, will increase your success rate by about 90%. Huge, absolutely huge. If you can't give non-steroidals, and there are situations when obviously we can't do that, paracetamols are not as effective, but they still increase the success rate to around about 50% of those that don't normally succeed. Also, if you've got a very hyperemic tooth, periplacin articaine, especially as an abscess, articaine, I've used. I'm not a massive fan of it, to be fair. For me, I don't think it gives me any advantages to just using other anesthetics. If I've got a tooth where the tissue is incredibly inflamed around it and it's painful, your lignocaine and adrenaline won't work very well because the pH is wrong. So the pH will neutralize your local anesthetic agent. So what you need to do, ideally, is change that pH before you give the local. If you can give bicarbonate mixed with saline, but we haven't got that as a dentist. But what we have got is Cytonest, and Cytonest will change the pH for you really, really quickly. So what I would always do is if I've got a really hyperemic tooth, the tissue around it is inflamed, I know that the chance the lignocaine, adrenaline, or articaine is not going to work as well. So I just put half a cartridge of Cytonest in there first, just as an infiltration, then put the lignocaine in. Doing that way, you can pretty much guarantee full anesthesia. Well, I cannot remember the last time I had to use a peripress. And as I say, I only do surgery. So it's still a technique, but as I say, using that will help, definitely. Okay, any questions on that? No, this is good. Does that make sense? Yeah, okay. I promise you it will. If you want any more information afterwards, just ping me an email. I'll do it through Tom, and I'll get back to you. Oh, hang on, sorry. Okay, any particular issues with comorbidities? I think for me, it becomes more of an issue now. We're seeing multiply medicated patients. I work mainly in private practice oral surgery now, but we're seeing an awful lot of patients who are on the endless NHS hospital waiting list. So they get shuffled to us when really they need treating in a hospital environment because of their medical history, even though they're walking around and seemingly quite fit and well, but you actually look at the medications they're on and think, okay, and perhaps not the best patient to be treating in a sort of a general practice environment, whether it's private or NHS. Medications, are you all fairly happy with medications? Oh, here we go. It's a question in just here. Methotrexate, do we send to hospital? Not necessarily, not necessarily. With any medication that the patient's on, if I'm unsure, check the BNF straight away, or ring up your local MaxVax unit. They'll tell you whether it's okay to treat. What about bisphosphonates? Are you happy to treat? Do we treat? Don't we treat? Oh, here we go. Liver disease and use of LA, yeah, you've got to be careful. You've got to restrict the amount of local anesthetic, and also you can get bleeding problems with that. So again, I would check if it's really severe liver disease, then I would check with the GP or the hospital consultant who's managing the case. Current thinking on alendronic acid. So alendronic acid is a bisphosphonate, or one of many bisphosphonates. So going back a number of years, I'm getting old, so I did one of the original papers on bisphosphonates in dentistry, and it was kind of weird because at the time I gave a presentation on bisphosphonates at Guy's Hospital, and I was virtually shocked by some of my colleagues afterwards saying I was mad. How could you say such a thing was a problem, because we didn't know anything about it. it can be a problem. Current status is we don't really know. Unfortunately, because there is no national or international database of patients who are taking bisphosphonates. We don't know how big a problem it is, but it is a problem. What we do know is that in general, treat bisphosphonate, yeah, I would agree, Alan. To be honest, if the patient is just taking oral bisphosphonates and it's less than 3 years, the risk is pretty minimal that they're going to have anything particular. The main issue with bisphosphonates is bisphosphonate osteonecrosis. So you just don't get healing. And I've seen a number of patients with it over the years. And the more you do to treat, the patient will come back often 3 or 4 weeks after an extraction, and they'll just be exposed bone. And the normal thing, I've got to clean it up and suture it back up again. You clean it up and suture it back up, and they come back a month or 2 later, and it's re-exposed. And you can keep chasing yourself because surgically, we haven't got the techniques to be able to manage it very well. In general, it's a kind of preventive thing. So most countries, and UK isn't one of them, bizarrely, most countries that have a restriction now with prescription of oral bisphosphonates of 3 years, because we know that after 3 years, that's when your problems with it intraorally with healing can increase dramatically. Below 3 years, as I say, the risks are fairly minimal. I would still, I mean, Tom will be glad to hear that from a medical legal point of view. I would still always paint the worst picture, say that, yes, we do know that bisphosphonates, they're a great drug and they're fantastic and they're taken for very important reasons, but they can affect, and it is just the mouth, it's just the alveolar bone that can affect the turnover of the bone, the healing, so that sometimes you can get delayed healing and sometimes it really just doesn't heal at all. In general, as I say, that's with IV bisphosphonates. Oral bisphosphonates, you're usually fine. There are several other drugs that are similar to it as well. If you're unsure, ring up your local MaxFax department or ring up whoever is prescribing the bisphosphonates. But as I say, I treat a lot of them. Do I do anything particularly different? I give them a 10-day course of amoxicillin because we have a reasonable amount of evidence to suggest that that is helpful. And I will start that 3 days before, but I'll often ask a question. So I'll ask a question of, have they had any dental extractions done recently? And if they have, and they've been okay, they're probably going to be all right as well. Okay. So how different between delayed healing with people with uncontrolled diabetes or people on bisphosphonates? So uncontrolled diabetes, diabetics, you often get patients who come in. I mean, I've had a patient recently we turned down for implants, lovely gentleman, and he's poorly controlled diabetes, and he had a foot operation done 18 months ago. It still hasn't healed. He's having to go back to having dressed and dressed and dressed. It's just the body just doesn't heal in some cases with some diabetics. With bisphosphonates, it's to do with the turnover of the bone. So you'll basically get exposed bone. And you cannot often get the body to heal over it. So it's a slightly different way of healing. And I say, I can show you some photographs afterwards, you will basically just get a necrotic area of bone in there. Currently, there isn't really anything predictable that we've got to treat it. That's the main issue. That's the main problem. So if you do create bisphosphonate osteonecrosis, it's quite difficult to manage. IV bisphosphonates, and that can be a problem. I'm seeing it more and more where patients are treated for ease, not for any other reason. They just go, oh, rather than giving you an oral dose and having to manage it, we'll just give you an injection once a month. They then become incredibly high risk of developing that osteonecrosis. And it can be horrendous. I've seen cases where they've basically had a hole into the maxillary sinus because they've lost all the bone and they're having to flush out the sinus every day because it just gets full of gunge. So it can be quite unpleasant. Okay. There we go. clinical assessment. So what do you want to know clinically? There was talk earlier on about how do you know whether a root is close to the sinus or in the sinus. With a normal flat film, with a PA or even a DPT, it's actually very difficult to tell. I will, if it looks to be close to the sinus, I will always assume that there's a chance that it's like go back to that one of the original slides. I'll always assume the worst. I'll always assume that there is a chance that after I've taken this tooth out, I could create a communication into the sinus, or I could push the root into the sinus. So I would look at just a normal flat film, assess that, and again, consent the patient. If it's something you're really worried about, and I'll go through this later on, but if it's something you're really worried about, it's a massively curved set of roots, very, very close, look to be incredibly close to the sinus, and you don't think you're going to be able to get out without shoving roots into the sinus, then refer it. There's absolutely no reason to try and put yourself through that trauma of doing it, and also the patient as well, because it doesn't, you don't win any awards for doing that. So just refer them on if that's what you're wanting to do. Okay. Clinical assessment, I will always want a radiograph of a tooth. So if I'm going to take a tooth out, that's what we're talking about with a lot of these cases, whether it's retained roots or whatever, I want to have a radiograph. It doesn't necessarily have to be current, as long as I can work out kind of what the current situation is. So if I get a referral in, or the patient comes in and they've kind of broken the crown off and you can't really see the roots, you've got an old x-ray, but it doesn't show you what's currently there, I'd take a new PA of that area, definitely, because you'd need to see what's there. Also, it will show you the closeness of vital structures and also closeness of nerves, anatomy, such as the maxillary sinus. Okay. And I'd want to check out the teeth next door to it as well. So if you're going to have to take a tooth out and you've got a lovely veneer or crown next to it, you need to be careful that you don't crack that veneer or crown. And over the years, I've been doing lots of years, I've done most things, sometimes more than once. And if it's very, very close, I would sometimes warn the patient beforehand that it's incredibly close to this really nice veneer or crown. It could get damaged. There is a small chance. Okay. Shared decision making. This was a very difficult thing when kind of dentistry was closed for so long, and then suddenly we reopened, and there was this massive patients who'd been had toothache for sometimes months. I think my first patient back when we reopened nearly 2 years ago, wasn't it, was a GP who was a regular patient of ours who'd been self-prescribing antibiotics for an abscess on a lower 6. He was mid-60s, Asian, diabetic. There was, as he said, there was no way he was going to go to A&E and potentially catch COVID, because he was perceived to be a higher risk. Sometimes patients, if they are in extreme pain, will come and say, oh, I want this tooth out. I think you've always got to, for me, I would always go through that decision-making process, make sure they're making the right decision, because taking a tooth out is a fairly terminal thing. And I don't know what sort of number of cases you have, Tom, from an insurance point of view, with patients coming in and sort of saying, well, I had this tooth taken out, but I wasn't offered a root filling, or I wasn't offered this or restoration. I certainly know in the literature it's there.
Yeah, I think it's very, very important that we see it a fair bit where patients make the accusation that they haven't been that they were forced into a procedure, or they certainly felt that way. So I think it's a very important point, well made.
Yeah, it's, as I say, it's a difficult thing with consent and shared decision making. I personally, I think it's my hospital training, I can't get it out of myself. Excuse me, I will always have a written consent. Whether it means very much, I'm not sure, but I will always do that, because that was kind of drummed into me during my hospital life. But it gives that patient, they're signing for the procedure that they know they're going to have, and I will put on there the kind of common complications that may well happen from it. So is that, as I say, that shared decision-making process there. A reassurance as to one, you're competent to do it. So don't push yourself into doing something if you haven't got either the confidence or the skills to do it, or the materials, if you haven't got the equipment to do it. So if you think this route could go into the sinus, how do I get it out? If it does go into the sinus, what do you do? And if you think it's almost certain to go into the sinus, don't start. Just let somebody else, let me push it into the sinus. It's my job to get it out again. Moderate the expectations of the patients. If it's going to be a difficult tooth to take out, if it's a difficult retained root, then yeah, advise them of that case. And the risks, always tell them the real risks that will happen. So pain, swelling, stitches, potential damage to other teeth, but that's fairly rare, to be honest. Okay, roots in the sinus. Well, there was a question earlier on about roots in the sinus. Would you, if you were to push a root into the sinus, or you see a root push into the sinus, would you leave it in, or would you want to take it out? I haven't put anything on this. Leave and refer, absolutely. Yeah. You're all correct there. So if there is a root in the sinus, you, particularly if it is had some infection around it, it will need to be removed. But unless you're happy delving in the sinus and digging around and finding a root, then just refer it on straight away. Just advise the patient what's happened and phone up your local friendly Max Fax or oral surgery department or consultant, and they will sort it out for you. Leaving it in, one of the first hospital, when I was a registrar a long time ago, one of the first cases I was involved with was a patient who was at a dental hospital, which will not be named, and they'd had a tooth taken out and with an upper molar, and they'd left the roots in, they pushed them in the sinus and left them in, and the patient died about 3 years later of a brain abscess from the tooth. So you don't leave them in. Whatever you do, don't leave the things in. But it doesn't matter if you're not confident to take it out, that's absolutely fine. I would, if you try and get me doing an endo or an impression, I will break out into a cold sweat. So we've all got our areas of expertise and skills. So it's quite reasonable to refer it on, but yes, it does need to be removed. Absolutely. Oh, sorry. There we go. Human errors, human factors. As Tom knows, we did a common human factors webinar a couple of years ago now, wasn't it? Human errors, wrong tooth extractions is actually quite common. Mick Horton did a really nice paper on it a couple of 2 or 3 years ago now. As did Simon Wright was involved in that, and it does happen. I don't know how much of that comes via medico-legal avenues where wrong teeth are taken out.
A bit.
Is it?
Yeah. More than you would expect, but yeah, we do see a fair bit. Yeah,
it's, for me, I would always, and again, this goes back to my training, we always have a whiteboard on the wall, so we will write on the board what we're going to do on the day. So, okay, that day I'm taking out particularly orthodontic extractions. It's so there was a lower left 4 and a lower right 5. Okay, you're going to make sure, and always double check. I'll have it on the screen in front of me. I'll have it on the board. We'll double check before you start putting your forceps or your luxators on those teeth, because once you're taking them out, it can become a bit of a problem. I've never knowingly taken the wrong tooth out, but I've certainly been present when that has been done. I have, when I was an SHO, I did take out a 7 and an 8 at the same time, which was an accessory tooth that I didn't mean to take out. That's slightly different. Okay, so one of the things we did in Manchester, which was quite good, is we just created a surgical checklist, which I can share with you afterwards as well. Really just so that we could ensure that this wrong tooth extraction was kind of addressed because it was a problem. It was a problem in dental hospital. We realized this a number of years ago. And we audited it. We audited it to make sure that everybody's checking at each stage. If you're we all have to do audit. Make your audit useful and beneficial to you to make sure things are actually being done. So we were checking, and even though people knew they were being checked, still only 8 out of 10 were actually completing everything. And how many completed the form fully? 43%. That's not great, is it? But there you go. We can mark them at teeth. It's a difficult thing, isn't it? It's we mark limbs when we're taking them out, and we mark an X on the body. But yeah, it is. As I say, I haven't taken the wrong tooth out, but I've been very close to it a number of times, where you kind of put the luxator in there and you look at it. Oh no, it's not this one, it's that one. The difficulty sometimes comes when you get a patient who comes in and they don't know where the pain's from. I think it's this tooth, I think it's that one. And again, it goes back to that initial thing. You've just got to be honest with the patient and say, well, sometimes it's very difficult to diagnose these things. The shared decision that we've come to, we and you, is that we think it's this lower tooth here, but there is a slim chance we're wrong. Just be honest. I think usually you'll get away with that. Okay, appropriate instruments. We all have our appropriate instruments. I have a minimal set of instruments, but one of the things I always do is I always get my instruments out before the patient comes in. It's just the thing I hate is when the patient comes in and they suddenly think, oh, I need to get that, I need to get this. Get everything out in advance. So if you look at it and think this could be a surgical, have your surgical kit out ready. Could be on the side. You don't have to take it out of the packets, but just have it out ready. The last thing you want is you've got a busy list, your tooth breaks, it's going to be a surgical, and then suddenly you've got to go and send your nurse off to go and find your surgical kit as to which surgery it's in and where it is. Just get it all out ready in advance. And that's something that I would always do. And I won't have the patient in until we've got all the instruments out and ready. So prior to the procedure, I'm a bit obsessive. I'll lay all my instruments out. I'll lay them all out to make sure I've got everything that I'll need for that particular procedure. I wouldn't have all of these instruments, but these are some of the instruments that I would have. Mirror, yeah, I'll always have a mirror in there, and a probe of some description, often just a perio probe, just so I can press the tissue just to make sure it's actually numb. The mirror, great for retraction, because access is a difficult thing with surgery, it can be. Mitchell's trimmer, yes, I pretty much always have on there. I won't use Howarth's, that's number 7. I should give you a spotter list, shouldn't I? Number 7, the Howarth's. Rate retractor, no, I don't use those. They're like a little sawtooth, so they'll chop your gum off very nicely. Couplins, I do have, but they're not my first line of attack. I have a set of forceps. I use a minimal set of forceps, really. And the top here, you've got a retractor, which I'll always use for the tongue. Bone nibblers. Get yourself some decent sutures as well. So suture holders, you probably want the ones with the gold handle. They have got an insert in the tip which will make them better. Don't try and use Spencer Wells artery forceps. Just get yourself a set of suture holders. They're only 20, 30 pounds. They'll last you a long time until you get some decent ones. And some number 21, little tissue forceps. Get some really delicate ones as well. It just makes it easier for yourself. If you want to get more experience in anything, you've just got to do it. You've got to do it over and over again. One of the things when I first started doing surgery was with suturing is that basically you got sent into a room with a whole box of sutures and various fruits and gloves that you'd make nicks in, and then you just suture them. You just suture and suture and suture. But what I also tend to do is if you're not confident in suturing, I would suture more. So start suturing in situations where you don't need to. Because it's all very well suturing on a glove when it's out of the mouth, or an orange or a banana or whatever it is. But when you're at the back of the mouth, it's actually quite fiddly to do. So just get into the habit of doing it routinely for some extractions so that it's not essential, but you just get that muscle memory in place. Okay. That would be one of kits. It's a lax retractor. I'll have that every time. And my assistant, my nurse, will hold that just to keep the tongue out of the way. When I'm working, when you're suturing, it also reflects a bit of light back as well. Okay, on the left here is a periotome, which if it's a retained root, one of the first things I'll do is go down the tissue with the periotome, and it just cuts through that periodontal ligament. I think they're a great instrument. This is Hugh Foodie, but many places you make these now. I'd use the ones that have already got the blades in as part of the instrument. The ones with separate blades, for me, just break. I just end up buying new blades every few months, which gets very expensive. But these ones here are pretty good. And then periotomes. Get yourself a couple of decent periotomes. I just tend to use the two sizes, a 2.5, 3, and then a 5. But that will be my kit for probably most extractions, particularly retained roots. There was a talk earlier on about retained roots. I'd want a radiograph. I want to get a radiograph straight away. And if I can't, I'll try and get an access with my periotome or with a luxator and try and just get it moving. If I can't do that, I'll just take a little small flat back just so I can see what I'm doing. Because sometimes as soon as you take that flat back and just remove all that scar tissue, suddenly it all becomes clearer as to where you need to put your instrument. Couplins, used in a slightly different way to a periotome, more of a rotation. Yeah, I do use these occasionally, 1s and 2s. Forceps, cow horned eagle beaks, however you want to be calling them. For lower molars, absolutely essential, especially if they're broken down. It will either pull the tooth out very quickly, or if the roots want to split, it'll just split the roots for you. So suddenly it makes you taking 2 premolars out rather than a molar. So it just makes it simpler. Get yourself some decent forceps as well. Some really nice narrow tipped forceps for getting roots out. After I've taken the tooth out, what I always do is clean the socket out. So just get a small curette or a large excavator will do it, or even a Mitchell's trimmer. Just clean any of the gunge out of the socket, clean any debris, clean any bits of broken bone out there, any granulation tissue. It's just going to help the healing. The top right here is a thing called a Pritchard Retractor, which I love. It's actually a modification of an instrument a number of years ago. So it's a flat plastic on one end, sorry, mixer on one end, and then an elevator on the other. But that for retracting tissues is great. It's very easy to use and very simple. And that's my basic surgical instruments. Then I say this is how you hold needle holders. Put your finger on the side of them just to support them. And this is the difference between a needle holder and the left here in B. You've got the needle holder on the left, and on the right hand side there you've got your kind of Spencer Wells artery forceps, which will make it very difficult to suture. I have done it because a lot of places don't have needle holders, but just get yourself a pair if you haven't got some, because they're not expensive. They're really not expensive. Also get a decent pair of scissors as well. And these are Adson's forceps. These are my preference, with a little, very tiny, they're called micro Adsons. These are just for holding tissues. So make things easier for yourself. Give yourself access to the area. So good light. We've obviously got a surgical lamp, but also I've got my headlamp as well, which I find invaluable. So as I get older, I can see less and less, so I need more light. And I also use loops pretty much all the time as well. Good access and vision all the way through. Positioning the operator and the patient. For me, kind of my surgical training, I would always stand on the side that I'm working. So if I'm taking a lower left 7 out, I will go to the left, and I will often move between left and right when I'm treating the patient, because you can sometimes see better when you're on that side rather than trying to always work from the side you normally work. Ensure you've got the soft tissues out of the way, and that's both your job with your kind of your other hand, but also your assistant's job. Make sure that they're keeping the tongue out of the way and the lips out of the way when you're both taking the tooth out, but also for suction, when you've got a retained root in there, they need to hold everything out of the way so you've got the best possible access. That's one of the difficulties with kind of doing surgery, plastic surgery, compared to max factor oral surgery. Oral surgery, you're working down this long dark hole, which makes it more fiddly. There's a good suction on there. Doesn't have to be a surgical tip. You can get little tips that go on the end of the normal suctions, will be fine, but a narrow suction makes it an awful lot easier. I use your instruments correctly. We showed you a little bit about the peritome on there already. Luxator couplings, correct forceps. Always get the right forceps for the right tooth. Protect the airway. I've certainly seen teeth go in the wrong place pretty much everywhere all over the years. I don't know if that's something that commonly happens, Tom. People swallowing bits of teeth.
We've definitely had. It's more we've had where instruments have accidentally, or part of an instrument's been accidentally swallowed. That was the more recent case that we had.
Okay, that's fine. So protect the airway, and that's your assistant's job. So you're taking bits of root out. Sometimes they come flying out, and you don't want it to go somewhere where it just disappears. So yeah, always protect the airway. So I get the assistant to protect the airway, and sometimes I use a little bit of gauze just to, if I've got so if I'm taking out anterior teeth and they're very loose crowns on them, sometimes when you're just kind of elevating, the crown comes flying off. So I'll often put a bit of gauze just behind it, so that if it does drop off, they're not going to try and eat it. I don't really want to do that. Always use a buccal approach. Don't go lingually. It's way too dangerous, and lots of things you can damage. Get the instrument in the right place. Don't use excessive apical force. And the question is, often it's controlled force when you're taking teeth out. You can, as soon as you put your forcep or your elevator or luxator on there, you kind of know which way the tooth wants to go. If it doesn't come out, and if it doesn't come out for me pretty quickly, I'll get the surgical kit out. I'll get the motors and various other things. And if you really haven't got that, either the equipment or the skills, abandon. If you know you can't get it out, just abandon it and refer it on. There's no benefit to damaging the patient more just because you think, I've got to get this out. Okay. Post-extraction management. I think that's something that I'm very keen on, particularly it was one of the hospital appointments I had in Manchester. The post-extraction care wasn't good. We're getting an awful lot of patients coming back in because they had problems and we couldn't manage them. So we kind of set together a process for making sure that when the patient was finished, it was really unlikely that they were going to have to come back. And that we do the same in practice. I will see any patient who comes back in pain. Of course I will, but I really don't want to. I want it one off here, off you go. So if we can do everything we can to kind of maximize our success, minimize the problems post-operatively, that's the key thing. So there's a question just up there. Hemostatic sponges. I'll tell you in a second, Craig. Sorry. Okay, so once you take a tooth out, I'll always run my finger around the socket walls, just to check if there's any sharp bits or any loose bits of bone. If there are, just a Mitchell's trimmer, just scrape them out, get rid of them. Look carefully down the socket, make sure there's no bits of gunge or granulation tissue in there. If there is, clean it out. Achieve hemostasis. So you take the tooth out, lower molar, fiddly difficult tooth, comes out, and then you look in the socket and there's no blood, there's no bleeding. Get your Mitchell's trimmer, get the pointy end of it, and just perforate that cortical plate lingually all the way around if you can, just through that socket, and that will get some blood into the socket. Written and verbal post-extraction instructions. Again, always paint the worst possible picture. It could be sore for up to 5 days. So we give them analgesics, and very, very rarely antibiotics. Analgesics we will give. Obviously in your situation, if it's an NHS practice, just advise them, it's cheaper. Just say, okay, well, non-steroidals, ibuprofen or paracetamol, you can take them both, but take them separately. There's no point taking them at the same time. If it's something that is really difficult, traumatic procedure, and that happens, it happens with always, it'll happen to me as well. We'll ring them the day after to make sure they're okay. How are you feeling? How are you feeling? For review afterwards, okay, Alexander, I'll have a look at that in a second. For review afterwards, if I do have to review a patient, I tend to try and review after 2 weeks minimum, because before that, if there's still pain, if it's still sore, that's just normal post-surgical trauma, and there's nothing I can do. it's going to be sore. That's just the way of it. So follow-up in general is 2 weeks. Loads of questions just there from. So hemostatic sponges, I think I'm going to get into in a second, Craig, and if I don't, I will go to that. I was told some years back in an induction session never to cure a socket after LAF. It's dangerous. No, I certainly, as an oral surgeon, would always curette sockets, Alexandru. So I would have no issues with that from a clinical point of view. At the end of the day, if you've got infected granulation tissue in there, it will heal, but it's going to take a long time to heal. And there's always a potential that it's going to cause a kind of source of infection. So just clean it out, curette it out. And so, yes, do I curette? Pretty much always. Only just a gentle curette out. But if there really is some gunge in there, then yeah, I want to get it out. And sometimes you can see on the radiograph, you've got your tooth and you've got this big shadowed area underneath it. So yeah, I want to clear that out. Be careful. If you're going to get close to a vital structure, then yeah, don't go scraping very, very close to the ID nerve. But yeah, I will pretty much always curette out. I'll flush it out with saline, but if you haven't got sterile saline, just use local. That'll be fine as well. So yes, I would always curette. I would back you up from a medical legal point of view if that was the case. Okay. Oh, sorry, wrong button. There we go. Oh no, sorry. Sponges. Sorry, Craig. There was a question about sponges there. Yes, I do. So if I take a tooth out, done an extraction, I'll compress the sockets, I'll compress the tissue around the edges, put a pack in there, and then I'll kind of write or tighten the notes up. We all do nowadays. Tighten the notes up, and then I'll look back to the patient. I'll take the pack out. If it's still bleeding significantly, at that stage, you can try and work out where the blood's coming from. It's not always obvious. Sometimes it's just soft tissue. If it's just soft tissue, I'll put a little bit more local and perhaps put a suture in just to kind of compress things a little bit. If it's coming from within the socket, which can sometimes be the case, I will put some sort of hemostatic sponge in there. It doesn't really matter which one you put in. You can use Surgicel, which is really expensive. Collagen sponges work well. I use those as well sometimes. If you've got a patient and they're kind of on some of these new anticoagulant drugs, they're a pain. So there are other materials I'll use for those situations. One's called Celox, which was developed by the military, but it works incredibly well. Again, if you need details for that, I can give you that afterwards. But sponges, only if necessary. I don't routinely put something into the socket. I think the more things you put in there, the longer it's going to delay the healing potentially. That's very correct. Okay. Yeah, follow up as appropriate. As I say, I do tend to follow up just a couple of weeks with a phone call the day after if it's something that's really unpleasant and I think will probably be quite sore. I'll always give them somebody will give them a call the day after. And if it's something you're concerned about, so if it's say a bisphosphonate patient or a patient with diabetes where you think, well, I don't know whether this is going to heal okay, it might be a little bit delayed, then I probably would see them perhaps 2 or 3 weeks afterwards just to check. I'll often take clinical photos as well. It's difficult to remember what it was like beforehand, but take a photograph and then take another one and just see how it's healing and compare it. Additional training, it's haphazard in the UK at the moment. We are doing quite a bit of work with the College of General Dentistry, so there is something coming very soon, which is good. One of the first things I do, give me a call. I'm more than happy to direct you. And also there are a number of hospital units where you can get a kind of a half a session a week. I think that's brilliant. With any of these things, the additional training is just that constant repetition, constant practice. So if you're wanting to do that, so I haven't put my email on here, sorry, schoolboy error, but you can get in contact with me through Rachel or Tom, I'm sure, and I can direct you as to where you could get further training in your area. And it may be that local hospitals are often the best places to ask because they're often very, very happy to have somebody work there just half a day a week.
Robert, I was just going to say, if so an easy way of getting in touch with you would be through the Entrepreneurs. So,
oh yeah, of course, yeah, there you go.
So any of you guys that haven't, if you join the Entrepreneurs, which is our Facebook community, Robert's often posting things in there anyway, so it's a good way to reach out to him. So if you need any help in that direction, then give me a shout. Yeah, if you search for Entrepreneurs on Facebook, you'll find us. And as I say, there's a lot of information in there, but you have the opportunity. There, Rachel's put it into the group, so there's the link. And yeah, easy way to get hold of us.
I'll put my email in as well. Okay. There you go. My email's on there as well. So if anybody wants to ask me anything, I'll do my best to answer. I may not know, but if I don't know, I'm sure I'll know somebody who does. That's the key thing. Okay, I think I've done my whistle-stop tour of oral surgery. If there's anything else you want to know about or ask, and then please feel free to ask me now. If not, ping me an email on our website. I don't know how many oral surgery courses we've got, about 20 or 30 recorded webinars on virtually every bit of oral surgery you can possibly imagine. So it's all on there. People who've used our website, and I know a number of you are members, we are literally just changing the way that things flow through. So we're making actually more pathways now. Gelatin, would you place them as they are, or do you compress the socket before placing inside the socket? I'd always compress the socket first. Yeah. Okay. That's fine. Okay.
Fantastic. Well, Robert, thank you so much. As I say, as a non-dentist, there was plenty of things in there that I didn't understand, but I still find it very, very interesting. So thank you so much. It was a brilliant hour. For those guys that join later, we will be making the webinar available to our members to get a copy and rewatch. So look out for that. Yeah, we'll be back in a month's time for the next one.
Yeah. Deepak, just a quick question about very fine retained roots where the luxator is too wide. Periotomes are really, really good for that. And I'll often use that for the really fine rooted teeth. You can also get Aerodental, and you can buy direct from the States. And they've got a set of really nice, narrow luxators that I only use in emergencies. They're kind of kept in a tray to protect them, but they're kind of 1 millimeter size, so they're small. So I'll use those for those sort of situations. But yeah, you'll always get some that are just too small. Okay, sorry, there's a lot of people asking about CPD. I suspect you'll be sorting that out with this.
Yes, leave that with us.
Brilliant.
Fantastic. Okay, well, Robert, thanks again. And thanks everyone for joining this evening, and we'll see you in a month.
Okay, take care, everybody. Good night. See you soon.
Bye-bye.
Cheers. Bye-bye now.